Yes, you're good to go.
Yeah.
Please start. Yes.
Okay. Thank you, everyone. I'm Mesfin from Ethiopia, and I'm presenting attributes for sustainable and trustable health solutions in low and lower middle income countries. It's a qualitative analysis report on task 4.2. Okay, as an outline, I will have an introduction, matrix section, ethical section, results, conclusion, and acknowledgement at last reference for this analysis. So, as an introduction, e-health is the use of ICT for health as defined by WHO, and it is mainly used by individuals, academic institutions, professional bodies, and funding organizations as well. This health solutions encompasses the clinical, administrative, and research areas. It is very important for access, safety, quality, and performance of healthcare services by improving the healthcare data management, and it also minimizes the cost, and it is also advantageous to reduce the medical errors. However, these technologies are not widely applicable in low and lower middle income countries as intended. And the objective of this study is to explore attributes of sustainable and trustable health infrastructures. So the study area are Tunisia, Ethiopia, Ghana, and Malawi were the study areas, and the data was collected from September to November 2021, and it's a qualitative approach by design. In program implementers, health solution developers, government officials at the ministry and regional levels, and facility and administrative and service providers. Participants were selected from these areas, from program implementers, from health solution developers, and from government officials, and from facility administrators. As to that of the later section, 49 key informant interviews were conducted face-to-face using a face-to-face approach. An interview guide was developed, and this interview guide contains the guiding and the probing questions. The data collection period took from 5, which is the minimum, to that of 39, which is the maximum days. A single interview took, the minimum interview is 21 minutes, and the maximum one is 150 minutes as well. All the data are collected using audio recorders. When we see the data analysis, verbatim transcription was carried out to convert the data from the local language to that of English. And we used open core software for analysis. To do that, multiple readings were carried out to identify emerging and recurrent ideas. These emerging and recurrent ideas were assigned a code for each. Those ideas or themes and recurrent ideas were finally thematized into 7 themes. In the ethical section, ethical approval was obtained, consent was taken, and participants were informed about the risks and the benefits of it. There was no personal identifier, and at last, all data were securely placed. As to the result section, as I've said earlier, that 49 key informants, 10 from Tunisia, 15 from Ethiopia, 13 from Ghana, and 11 from Malawi were participated. And the age, when we see the age section, 40.8% of the participants were within the age category years, and 73.5% of the participants were male by sex. And at the same time, 71.4% of the MSc and above by education. The minimum work experience of a participant is 2 years, whereas the maximum one is 35. And there terms as
Araya, you are currently muted, and we can hear you now. And also your screen is not shared anymore, so I think there's a technical difficulty with the connection. Yes, your screen is back, so I hope your voice is also back. Maybe you're still muted. Yes, you are still muted.
Yeah.
Yeah.
Sorry for that.
You're back.
The first term is user or individual related, and the second term is human resource and capacity building, and the third one is economical, and the fourth is infrastructure, and the fifth organizational. The sixth one is technology, and the last term is policy and legislation. When we see the first one, age, education, experience, motivation, ICT skill, and user perception and awareness are identified as facilitators for a health, sustainable, and trustable health infrastructure. It is supported with a code that a participant from Ghana stated that those in the older age brackets are less likely to use it compared to the young one. They pushed their tablets to the young nexus to demonstrate, and I asked them whether their training. So the young one should use and demonstrate to move the health system. Here we can see that how age influences the use of health technology. And as to that of the barrier section, culture and practice, fear of technology, resistance to new technologies or resistance to change, lack of knowledge, lack of acceptability, low confidence in the digital solutions are some of the barriers for sustainable and trustable health infrastructure. There is also a code for this. Participants from Tunisia stated that the native habits, culture, and practice of end users can prevent them to accept new healthcare technologies and consequently can lead to fear of changes. For example, elderly doctors cannot accept and to communicate and coordinate with new stakeholders such as data managers and system administrators. This highlights us that how fear of technology or new initiatives are how they are influenced by new technologies, how participants or how end users are influenced by new technologies. Whereas in the second one is, when we see the second one, availability of trained human resource, training opportunity, and adequate budget for training are the facilitators for sustainable and trustable health infrastructure. The same thing, there's a code for this, which supports. A participant from Ghana stated that human resource should be enough to run 24 hours to prevent delays in some delivery. Human resource should be available or strengthened to keep the system running when it goes down. Whereas in the barrier section, shortage of manpower, staff turnover, lack of technical support, low digital literacy, misallocation of human resources, and inadequate capacity building were identified as the major barriers for sustainable and trustable health infrastructure. And a participant from Ethiopia stated that no one maintains our medical technologies like the CT scans when stop working, but are maintained by someone who came from other areas, which are the sources of our treat and difficult to trust the care organizations that provide the technology, since they don't want to give full responsibility of us. This highlights us how technical personnel are very important to secure the sustainability and trustability of a health infrastructure. And the third one is about sustainable and trustable health infrastructure, budget allocation, financial support, affordability.
Araya, we cannot hear you again.
Budget allocation, financial stability, and profitability of technology. Yeah. Yes,
I think there was a small hiccup again with your connection in voice. So we stopped hearing you for, I think, 5 or 6 seconds. But if you start from here, facilitators, economic result related, then I think we didn't miss anything.
No. Okay, I'm on the economic barriers and facilitators section.
Yes, that's good. Start from here. Yeah.
Yeah. Can I talk on this one?
Yes.
Yeah. And as to this section, budget allocation, financial support, affordability, profitability of technologies are identified as the major facilitators for trustable and sustainable health solutions. A participant from Tunisia also stated that the availability of sustainable funding and solid sponsoring are major facilitators for the implementation of sustainable health solutions. Sufficient budget should cover the implementation of appropriate ICT infrastructure, including software, equipment, network maintenance, updating, and end users training. This tells us that how financial securing of finance is very important for sustainability of a health infrastructure. Whereas in the barrier section, high cost of digital solutions and scarcity of financial resources are the major ones. And the participant from Ghana stated that the e-health is not free, internet is not free, so that this interestingly more expensive here in the developing countries compared to the developed countries. It highlights us how developing countries are suffering from financial scarcity to scale up and to run health solutions successfully. When we come to about the infrastructure related facilitators and barriers, reliable electricity power access and strong reliable internet connection and power backups were identified as major facilitators for sustainable and trustable health infrastructure. And it is also supported with a participant saying by Ghanaian that the internet gives us access to travel beyond our geographical location and have access to other important and other information sharing. So if we don't have a reliable internet, which has a high availability in terms of capacity to transmit information both in and out, it is also going to invade our communication within the outside. So it highlights that internet facility and networking is very important to sustain a health infrastructure. As to that of the barriers, lack of infrastructure, inadequate land coverage, poor electric installation, and frequent power interruption are the common ones. A participant again from Tunisia stated that I don't trust the sustainability and trustability of the existing infrastructure because frequent interruption and poor electric installation, poor electric installation, poor internet connectivity are the major one to implement a health solution, and it needs more strengthening and improving. So this code will help us that infrastructure is very important for sustainable health solution. And the other is end users, as to that of the organization, related end users involvement, organizational structure, availability of organizational readiness, and culture of information use are very important for sustainable and trustable health solutions. So a participant from Ethiopia also stated that inviting end users during system development should be considered and widely understood the environment is more important. Creating a sense of ownership should be there to use and sustain any health solution. Here, it tells us that how involving end users is very important to make the end users sense of ownership. As to the barrier section, lack of homegrown system, low culture of information utilization, delayed bidding and procurement process, lack of leadership support, and lack of incentives were identified as some major or the potential barriers for sustainable and sustainable health infrastructure. So a participant from Ethiopia stated that it is good to use and integrate open source with homegrown software. It is dangerous to rely on open source alone because one day when things go away, it can lead to a devastating outcome. So in-house developed health solutions are more trustable than open source and partner-based systems. This highlights us that homegrown softwares are very important for sustainability of the health solution. And the last one is about, sorry, was the last, of course, availability of strong data security, ease of use, user-friendly, system ownership, availability of data facilitators for trustable health infrastructure in the technology part. So a participant from Ethiopia stated that electronic system is very prone to data breach unless strong security is measured. So creating how to access the data of individuals is important because who is going to access, why and when should be clear in the data sharing practice as well. Whereas in the barrier section, complexity of the system, lack of interoperability, weak data security systems, and immaturities, they are very important and they are barriers for sustainable, not to have sustainable health infrastructure. So a participant from Malawi stated that fairly straightforward workflows will spur uptake of the systems. On the other hand, we have noted that complex workflows will leave most users frustrated. The seventh one is regarding policy and legislation. So accountability, lack of standard, availability of policy, legislative frameworks are very important for the sustainability and trustability of your infrastructure. A health strategy and operational plan with detail related to all required resources, including budget, human resource, ICT infrastructure, hardware and software, and internet connectivity can help to ensure the successful health implementation. And it is stated by a participant from Ethiopia. Whereas lack of policy and legislation and lack of standards are the potential barriers for and trustable health infrastructure and health solution as well. So a participant from Ethiopia stated that we don't trust software offered by external sources because when they become disappointed at some point, they could demolish the system just as Tulane University did in the past. When they left the country, they do not offer the source code of HMIs, MR, and HIs on which our health system relies. This tells us that there should be a clear legislation and policy whenever health systems are developed, and ownership is very important as well. In conclusion, there were 7 identified terms, whereas lack of adequate budget, lack of trained manpower, lack of adequate infrastructure, and frequent power interruptions are the most common factors identified by country for sustainable and trustable health infrastructure. As a limitation, very key participants were missed because of their previous exposure. That means some of them were participated earlier in other work packages, so that we missed them to be as a key informant for this interview. And the other challenge is unable to complete the interview. Most of the time, we faced this problem that participants will not finish the whole interview, and there were dropouts. So this was the challenge for many of the for some countries or partners. So this is finally, I would like to acknowledge the BETTEReHEALTH project, the partners, the University of Gondar, the study participants, and all of you, and some of the references. And I thank you.
Thank you, Araya, for this great presentation that gives good insights in all the barriers that still need to be taken for for a good implementation of e-health across the African continent, especially in the countries that were the participants were interviewed. May I remind all participants still on the webinar, if you have any questions, you can put the questions in the Q&A section at the bottom of your screen. Because of timing issues, I would suggest that we go to the next speaker, which is Siri Bjørvig from Norway, for giving us an insight on personal e-health developments in Norway. Siri, are you available? Are you ready? Are you?
Hello, everyone. Yes, I'm ready.
Floor is yours.
Can you see my screen in full screen?
Yes, full screen, yes.
Okay, perfect. Then I will start. Thank you for the invitation to present at this webinar. I'm Siri Bjørvig. I'm one of the directors at the Norwegian Center for e-health research. And I will give you some overview and some specific examples from the work with e-health implementation in Norway. I represent a research center, and we went from being the Norwegian Center for Integrated Care and Telemedicine into being the Norwegian Center for e-health research in January 2016. We are also a WHO collaborating center, and our main objective is to support national needs for research and analysis in e-health. So, and to give you some background information, Norway is a sparsely populated country with 5.2 million inhabitants. And the Norwegian healthcare system is mainly public organized in 4 hospital trusts, and there is more than 350 municipalities in Norway, and they are responsible for the primary care. And then in addition, we have the GPs, general practitioners, who are private but contracted by the municipalities and are the gatekeepers into our public healthcare system. And then we have a political white paper. It's dated back from 2013, but it's still very valid for the development of e-health in Norway. It's called One Citizens, One Health Record. And this is, it's more a metaphor than aiming to have one health record system. With the three aims: to have simple, for healthcare personnel to have secure and simple access to patient and user information, that the citizens have also simple and secure access to digital services, and also that data must be accessible for policy improvement, health surveillance, governance, and research. And of course, to operationalize all these aims, there is a lot of initiatives and and activities in Norway. And some of the current activities are the health portal to improve and increase the numbers of services available for the citizens. We have activities around the summary care report, e-prescription, electronic messaging, an own program for health data program, and also for the infrastructure. And last but not least, the personal connected care program. And it's actually this program I will talk more about in my presentation. And also it's a good example on long-term work. I've heard several of your presentations today, and all of you have talked about the complexity, the process, and also the last presentation about experience and the study you did. And I think most of the barriers are worldwide, and I could really relate to all the challenges. So this was interesting. And for this work, establishing this national program for personal connected health and care in Norway, or welfare technology, that is a term we use in Norway. Someone use ambient assisted living. So it has all different terms, but aiming of empowering people at home with the goal of having people to stay safe, to be empowered, but also to stay as long as possible at home. And this program, before the program officially started, it was a long-term work with doing the analysis. There was a lot of several white papers and other mapping recommendation done to put this on the political agenda. So this program was officially started in 2013 and run until 2021, but now it has also been extended, this program. And in this program, the municipalities are included and are encouraged to be a part of the national program. And today, more than 80% of the Norwegian municipalities have different activities trying to implement services for their inhabitants. And the way the program support the actors in Norway is by implementation grants. They provide implementation support, create guidelines for the municipalities. For example, there is a guideline called ABC of welfare technology in Norway, and I know SINTEF, who are coordinating the BETTEReHEALTH project, were also a part of developing this guideline for the program and further to the municipalities. The program arranged a lot of conferences, workshops, seminar, meeting place where the municipalities can meet and exchange experiences. And the program also make recommendations to the municipalities. So what kind of technologies are we talking about? And in the beginning, they divided the different phases into development phases and activities or project with for implementation. And in the beginning, it was technology for safety and empowerment at home, of smart home technology, medicine dispenser, electronic door lock, in a way simple technology which didn't require much interaction between different sectors in the healthcare. It was more one-to-one. So these kinds of technologies quite soon went from the development phase into implementation phases in the municipalities. But even though we think of it as simple technologies, it has been complex and difficult for the municipalities to implement them. And a lot of the reasons are the same as in the previous, as you were presented in the previous presentation. That's also the status in Norway. A lot of several of the same barriers in Norway. And then we are also in more health sensors, remote care, assistive technologies, which I would say have a higher complexity in the implementation of it. But many municipalities in Norway are now implementing, and of course the COVID-19 situation made it easier, and the speed also went up in order to implement technology. And then the question will of course be how to make it sustainable, because we see in some areas, especially in video conferencing, which have had a renaissance in Norway, and I assume all over with the pandemic, that it really increased the use. But as soon as we have periods with when it's possible to meet, then we also the traffic numbers of video consultation goes down. So this was a short presentation about the situation in Norway, and especially for this national program. So thank you very much.
Thank you, Siri, for the little insight. It's always too short, of course, such a presentation, but for the insights in the developments in Norway. Again, if there are any questions for Siri, please put them in the question and answer section at the bottom of your screen, so we can come back to them after the final presentation of the day, or we get back to you to the people person that answered put the question there offline after this session. So Celia, I would like to thank you, and I would like to invite the last speaker of the day, which is Charles Anachanser, I think. I'm not sure. If yes, you are here, Charles. If you can share your screen, if you have a presentation, and unmute yourself, then you can start with your presentation on the human factors in Ghana. Charles, are you here? Yes. And full screen, so you're ready to go.
Thank you very much. So okay, so I'm looking at electronic health records implementation, creating appropriate staff and then patient experience. My name is Charles Anachanser, the head of IT Korle-Bu Teaching Hospital in Accra, Ghana. So the content of my presentation, I'm going to look at a bit of a background. We will look at staff preparation before the e-health implementation. We would also look at patients awareness before e-health, the e-health implementation. Then I intend to look at a bit of resource challenges and then some lessons that we learned. All right, so the first thing I want to talk about is e-governance project as a background from some decade ago in Ghana. There was a need for us to look at how we can bring electronic or paperless connection in the entire country, and therefore the government picked it as an e-governance project. Out of the e-governance project, there was various forms of project under it. There was network infrastructure project, which made the government decided to put infrastructure in place in all the hospitals in Ghana. So Korle-Bu, from where I'm speaking from, had the advantage of having a fiber optic cable in the entire hospital. And then we have various forms of access points that connected the network together. Then we had some hardware computing devices that will enable us to run the software. And then we had the e-health software application itself. The Ministry of Health introduced the LIMS to us. LIMS is Light Wave Health Information Systems. It was introduced to the teaching hospitals in Ghana. Korle-Bu Hospital as a national referral hospital. We also had at the Middle Belt, Comfort Anoche Teaching Hospital, Kumasi. Then we have at the northern side, Tamale Teaching Hospital, Cape Coast Teaching Hospital, and then Whole Teaching Hospitals. These were the teaching hospitals that the e-health system was first introduced to. Then, in order for us to be able to start, we did what we call staff preparation before the EHR implementation. There was staff awareness creation. What I mean by that is that there was a need for us to be able to create awareness to the staff where we are going from paper environment to a paperless environment, or what we say from the manual environment to the electronic environment, which brought about a change management system. Yeah, before I continue with the change management system, we are still continuing it, even though we have done the implementation, because there's a need for both those who are in the front end and the back end to still get to understand that there is a change as we go ahead. So what we did was that we did create awareness for them to understand that we are moving from the paper environment to the electronic environment. Then we did what we call appropriate training. There was a need for us to do stakeholder involvement. We believe this will make the users, or will make the people own the system and use it as a system for them. And therefore we brought all the people that are involved from the front end and then the back end. I'm talking about clinicians and then directors in terms of human resource, finance and administration all together. Then the next point was we did joint application development. This enabled all the people involved to, first of all, look at the system from the vendors. So the system brought to us how the process flow is, so that we can be able to look at it and then tell them what we will need or what we'll customize for what will be a customization for us in Ghana, and for that matter, Korle-Bu Teaching Hospital. So we did a strong joint application development, and after that, we changed the various flows, because, for example, if you come to the hospital, there are various departments. If you pick the A&E department, the process flow at the A&E department will be different from the process flow at the children's department. The same applies to the process flow at the Department of Medicine. So we did a complete joint application development where everybody had his process flow brought out. Then it was given back to the people, or in other words, the vendors, to bring it back or to put it in shape for the department. Now, at the end of that, they brought it back to us for us to look at it. That's what they call the user acceptance test. So, for example, if they brought accident and emergency process flow during the joint application development, we put all that together and then created the way we wanted it. Then at the end of the day, they brought it back for us to use it and accept it. Once the acceptance was made, we did an actual training for all the staffs. once again, both the clinicals and the non-clinicals, or what I call the support staff. After training them, then we thought that we cannot just go live. There was a need for us to do what we call simulation, or what we call a piloting. So we did a simulation where we created a center so that all the people that are going to use the system will practice it until before we come to the main go live. At the end of the simulation, we did a piloting of some department. There was the need for us, because the hospital is so big, it's the second, or if I would say the third largest hospital in Ghana, over 3,000 bed capacity hospital. So we are looking at departmental by department, because if we should go live at a stretch, it's going to be of a problem. So we pick one department after the other so that we can pilot it. Once we are able to learn from all the challenges therein, then we can go live. So that is what we did. And then we started with the gatekeeper system in the hospital. We called on the polyclinic. Then from there, it came to the accident and emergency. Then it expanded or scaled up to the children's department, then to medical department, surgical department, and the rest. So that's what we did as a form of preparation before we did the implementation. Then there was a need for us to also look at upgrading our existing network infrastructure. Yes, the government was looking at the e-governance in terms of the infrastructure, but we also internally needed to look at our existing network infrastructure so that we can be able to have the doctors, both doctors, nurses, and the other staff use it, because we don't want the process whereby they'll get onto the system and then there will be, downtimes, network downtimes, and then it will discourage them. So we had to look at that. We also look at provision of hardware computing devices. Yes, the system came with some allotted machines from the Ministry of Health, but that wasn't enough. So the hospital itself would have to come up with, a bigger or a number of hardware so that we can be able to get the system used. Then there was also a pre-digitization of existing folders. This was a major thing because we're using the manual system before the electronic system. And therefore, there was a need for us to look at, okay, so when we get onto the main e-health system, what happens to the old data? What happens to the old folders? So we did a pre-digitalization project where we have to map all the old folders together, ready to be able to join the existing system that we have implemented. So that is what we did for that of the staff. Now, regarding the patient experience, there was a need for us to, yes, again, create patient awareness, make them understand that, yes, we are now going onto a system. So we are moving from more of folder system now into electronic system. The need for them to understand that they are no more going to have their documents, how do we call it? They are no more going to have their medical folders to be taken home. There was a point in time where we have to give their folders back to the patients when they come for review and consultation back home. But once we are going into the EHR, there was a need for them to understand. So we create awareness for them that they shouldn't have any fear. Yes, we are continuing with the same thing, but then this time around, we shall keep their folders, we will digitize it, and then they can continue with the electronic system. Then we also made them aware that they can now do appointment scheduling system, because the system allows us to be able to do appointment scheduling. And therefore, patient time over in the hospital becomes something that is going to be good, of which we really benefited. Because you see, a patient would have taken a whole number of hours to spend in the hospital. But with the implementation of the system, there was this time shortage or time curbing. We're able to curb the time that the patient spends in the hospital. So there was a need for them to understand all these things. Then again, those days when you come to the hospital, when investigation is done, whether it is lab investigation or imaging investigation, you will go back to for example, if it is radiology department and there was an MRI or a CT scan or fluoroscopy investigation that you did, you would have gone back to that department to pick your results. The same applies to labs. If you did any investigation like BUE, fasting blood sugar, you would go to that place and get the results. But there was a need for us to let them understand that you wouldn't need to now come back again to go to the radiology department or go to the lab department for your results. You just need to go to your consultant, and therefore, once you get there, they are able to quickly look into the system, access the resource, and then make medical decision. The next important thing was for them to understand that accessing medicines is not going to be directly at the pharmacies. The hospital is so big, so we have about 24 departments, and out of these 24 departments are sub-pharmacy departments, and therefore, once you are able to go through the entire system, the patient journey through the system, if you're an outpatient, you will go to the pharmacy department, and because it is connected together, and because of the links or the lightweight health information management system, you will then go directly to the pharmacy department, and then with your unique identifier or your unique number, you are able to access your medications, and then you can go home. Or if you are an inpatient, you can still access medication directly from the pharmacist. There was another thing that we also did, which has to do with mobile app support for pharmacists, so that those who will come as outpatients, patients who doesn't have or who may not have gotten medicines on the spot will leave their numbers, will use the app to be able to contact the hospital, so that once their medicines are ready, it can be taken up to them at their various homes for a fee. So having said this, we had some few challenges. Of course, the pre-digitalization was not completed, because you cannot just leave all that knowledge bank, because we realized over the years, the hospital in the next 2 years will be 100 years. So if you are looking at all these medical folders, you cannot just throw that away and say you have jumped onto a new e-health system. And therefore, we have done what I would call a blueprint for the digitization, the pre-digitization, but we have not been able to complete it. We've not been able to integrate it where the doctors can still pull up the old system to continue with the new system. So that is what we are on now, to make sure that we are able to finish with that. Otherwise, it will mean as if we've cut off completely the old system. One thing I also want to say about this is that, yes, in as much as we have started a system and using it, we started at a point, because we realized that if we are going to do pre-digitalization before we start a system, it's going to be, we won't start today. So there was a need for us to agree and start at a point once we work out the blueprint in order for us to continue with the digitalization. Now, the next is the limited number of computing devices for the e-health implementation. We realized that computers given to us officially from the Ministry of Health was really limited. So the hospital needed to come up with a plan to be able to purchase, because you cannot say you are going to implement or do e-health when you don't have hardware computing devices. So there was a need for us to, bring about a number of computing devices for them to use. And because of that, in as much as we agreed to get that, there were a lot of delays of the requested IT equipment and accessories, a lot of delays of them. So it poses a lot of challenges. So I said here that untimely delivery and deployment of the equipment posed the biggest challenge to the e-health implementation in the hospital. I think that is one of the things that really brought a bit of challenges when we went live with the system. But so far, so good. What I can share is that we have gone live. Yes, I can say for now, we are 70% complete. There are other important departments that we need to bring on board. That is more of like a back end like the laundry department, the kitchen department, and the engineering department, where we have to bring out systems to be able to alert machines when they are due for maintenance and all the like. Another challenge we realized, which I didn't put on this slide, was the need to be able to integrate the biomedical equipment well, and to also look at the cyber threats that comes with it, so that we can be able to get the machines, for example, MRI or any other system that is connected to the e-health system, to be able to directly send results into the LIMS system for doctors to be able to access it and make quick medical decision. So we are looking at that, and also looking at the need for security and cyber threats in this biomedical equipment, as well as our hardware computing devices that this may pose. So we have benefited from it. Yes, the fastest way I would say before I end this presentation is that revenue is increasing as compared to when we're using the manual. The various departments who have gone live with the system, yes, thumbs up for it, because they are getting much more revenue increase. In as much as there are still leakages, we see more revenue increase in the department that has been deployed. So this is what I will say in ending. It has benefited us. We've learned our lessons. The need for us to be able to get more equipment before we start the thing. But so far, so good. We are on it. And then the last but not the least also has to do with the teaching hospitals coming on board. Ghana Health Services also coming on board. My boss, Mr. Kwashi, already presented the regulatory framework. Yes, it was then the teaching hospitals, but now the Ghana Health Service are also on board. The beauty about all of us coming on board as one zone is that when a patient is transferred from, for example, the Tamale, the northern part of the hospital, and that person has been referred to Korle-Bu Hospital, which is a national referrer, before you get here, your medical history and everything is already in the system. So there is a point in the system where you call it global search. You go into it and pull the patient with his unique identifier or his unique ID. Then you can be able to continue consultation from there. These are the benefits. Otherwise, when a patient travels from Kumasi, Cape Coast, or Whole Teaching Hospital and come, you are going to start all over again. You start, the process again. But this system has benefited where once a patient is in the system, or you the system to check whether the patient is in the system, you can continue directly from what we call continuous care. So I believe that this has been a benefit to Ghana, and for that matter, Korle-Bu Teaching Hospital. Thank you very much.